We start our presentation today about the anterior abdominal wall and esophagus, starting with the anterior abdominal wall. The boundaries of anterior abdominal wall. The anterior abdominal wall extends from the xiphoid process and the costal margin superiorly to the pubic crest and iliac bones inferiorly, and the mid-axillary line on either side. The anterior abdominal wall is divided into 9 regions by 2 vertical lines. These are the vertical line, the right and left midclavicular line, and 2 horizontal lines, first subcostal plane at the level of L3 vertebra, and the second intertubercular plane at the L5 vertebra, which connect the 2 tubercles of iliac bone. So divide the abdomen into the right upper side, right hypochondrium, the epigastric, the left hypochondrial region, the left lumbar or left flank region, the umbilical region, the right lumbar or right flank region, right iliac fossa or right inguinal region, the hypogastric or suprapubic, and left iliac fossa or left inguinal region. The component of the anterior abdominal wall starting from the skin, the most superficial one, and then the superficial fascia, which consists of 2 parts, the outer superficial one, the camper fascia, and the deeper membranous layer, the scarpa fascia. Then the muscle of the anterior abdominal wall, starting from the external oblique muscle, the internal oblique muscle, and the transverse abdominis muscle. Behind the transverse abdominis muscle is the transversalis fascia and the properitoneal fat, which separate the transversalis fascia from the parietal peritoneum, which is the last layer of the anterior abdominal wall. The superficial fascia is divided into superficial fascia layer, the camper fascia, as we mentioned, and the deep layer, the scarpa fascia. The camper fascia is continuous with superficial fat over the rest of the body, and in the scrotum is modified as a thin, smooth muscular layer called dartos muscle, while the deep membranous layer, the scarpa fascia, superiorly continuous with the superficial fascia over the remainder of the trunk, and in the midline it is adherent to linea alba and pubis symphysis, while inferiorly it fused with the iliac crest, fused with the fascia lata at the inguinal flexure, and extend to the scrotum to become continuous with Colles fascia. This diagram shows what we mentioned. This is the camper fascia that is continuous with the fatty layer of the subcutaneous of the remainder of the body. This is the deeper part of the superficial fascia, the scarpa fascia, here continuous with the perineum and scrotum with the Colles fascia, and here fused with the fascia lata at the inguinal flexure. Here from the side, we see this is the camper fascia superficially, while in the scrotum, this is the brown, become the dartos muscle. So it is continuous with the dartos muscle. While the blue line, the scarpa fascia, which is the deeper part of the superficial fascia, here in the scrotum and in the perineum, continuous with the Colles fascia. Then the muscles of the anterior abdominal wall, starting with the external oblique. The external oblique arise from the lower 8 ribs and inserted into the linea alba, pubic crest, inguinal ligaments, and the iliac crest, as we see the direction of the fibers downward and forward. The internal oblique muscle. The internal oblique arises posteriorly from the lumbar fascia, then from the iliac crest, and lateral 2/3 of the inguinal ligament to be inserted into the linea alba and the costal margin. Here, the direction of the fiber lie upward and forward. This another picture demonstrates the difference in the direction of fibers. Here, the external oblique, the direction of the fibers downward, while the internal oblique direction is upward. The third muscle is the transversus abdominis muscle. The transverse abdominis muscle arises from the lower ribs and interdigitating with the diaphragm muscle and the lumbar fascia, iliac crest, and lateral half of the inguinal ligament to be inserted into the linea alba. The fourth muscle is the rectus abdominus muscle, which is a thick ribbon of muscle lie on the either side of the diaphragm, either side of the midline, and extend from the costal cartilage of 5th to 7th rib to the pubic crest. It has 3 to 4 tendinous intersection that adherent to the anterior rectus sheath. Pyramidalis muscle is a small triangular muscle absent in 10 to 25% of population and originate from pubic symphysis and pubic crest. Here it originates from pubic and inserted into the line elbow. Rectus sheath is a sheath formed by the fusion of aponeurosis of the flat muscles, external and internal oblique and transverse abdominus muscle, which enclose the vertical muscle, rectus abdominus, and pyramidalis muscle. The rectus sheath is divided into up and below the arcuate line. Above the arcuate line, the anterior layer or anterior rectus sheath is composed of the external oblique aponeurosis and anterior layer of the internal oblique aponeurosis. Posterior rectus sheath above the arcuate line composed of the transverse abdominus aponeurosis and the posterior layer of the internal oblique aponeurosis. This above the arcuate line. When we move to below the arcuate line, only the anterior layer or anterior rectus sheath is present and composed of the aponeuroses of the external oblique, internal oblique, and transverse abdominus muscle. This diagram demonstrates what we has explained. This is the arcuate line. This is the cut section above the arcuate line, showing here this is the rectus muscle. The anterior to the rectus muscle, anterior rectus sheath formed by the aponeurosis of external oblique and anterior layer of the internal oblique aponeurosis, while the posterior rectus sheath is formed by the transverse abdominus aponeurosis and the posterior layer of the internal oblique aponeurosis. While here below the arcuate line, this is again the arcuate line, and this is the cut below the arcuate line. So what will happen here is the 3 aponeuroses of the 3 muscles, the external oblique, internal oblique, and transverse abdominal muscle aponeuroses will converge anterior to the rectus abdomen muscle, leaving the posterior surface of rectus abdomen lie in contact with the transversal fascia that separates it from the parietal peritoneum. The properitoneal fat is a layer of fat separates the muscles of the anterior abdominal wall from the peritoneum and the abdominal content. This is the properitoneal fat as demonstrated. This is the muscles of the anterior abdominal wall, and this is the parietal peritoneum. So it separates the anterior abdominal wall muscle from the parietal peritoneum. Umbilical ligament. The posterior surface of the anterior abdominal wall has 3 umbilical ligaments. First, the median umbilical ligament, which is a fibrous remnant of the urachus, which run from the fundus of the bladder on the deep surface of the anterior abdominal wall to the umbilicus as a cord of variable thickness. It is covered by a fold of peritoneum. The second one is the medial umbilical ligament, which is a fibrous remnant of the obliterated umbilical arteries and run from internal iliac artery to the umbilicus on the deep surface of the anterior abdominal wall, is also covered by a peritoneum. The third one is the lateral umbilical ligament, which describes the inferior epigastric artery and its covering fold of peritoneum, as it passes superior medially from the external iliac artery to enter the rectus sheath posteriorly. This picture demonstrates what we mentioned. This half is covered by peritoneum. Here is the peritoneum removed. First, this is the median umbilical ligament, passing from the fundus of the bladder to the umbilicus, which is, as we mentioned, the remnant of the urachus. This is the medial umbilical fold or ligament. When we remove the peritoneum, here we see the remnant of the obliterated umbilical artery passing from the internal iliac artery to the umbilicus. The third one is the lateral umbilical fold. When we remove the peritoneum, we will see the inferior epigastric artery passing from the external iliac artery to enter the rectus sheath posteriorly. This, in cross section, as we see here, this is the median umbilical ligament and the medial umbilical ligament, here covered by the parietal peritoneum as they lie in the properitoneal fat. Radiological feature of the anterior abdominal wall, starting with the plain film of abdomen. The muscle layer of the anterior abdomen are outlined, especially in obese patients, between the subcutaneous fat line and the properitoneal fat line. However, clearly seen fat lines indicate the lack of edema in these areas. Although in 18% of normal radiograph, the properitoneal line is absent. Here is the properitoneal fat. This is the muscles of the anterior abdominal wall, and this is the subcutaneous fat. The radiolucent area is the fat, and the muscles in between. This is another picture. This is the faint radio-oblique. You can't see it. Is the internal oblique muscle, and this is the another radio-oblique is the transverse abdomen, and the faint line, radiolucent line in between is the fat layer between the internal oblique and transverse abdominis muscle. The radiolucency adjacent to the transverse abdomen is the properitoneal fat. When there is pneumoperitoneum, the air can outline the ligament, umbilical ligament, and we can diagnose pneumoperitoneum when the patient in supine position. Here, this is the lateral umbilical ligament in a sign called inverted V sign, outlined by air. And this is the median umbilical ligament, also outlined by air, called Eureka sign. The second investigation is ultrasound. Dynamic ultrasound is the key examination for assessing the groin or anterior abdominal wall pain. Dynamic components of examination include Valsalva and compression maneuver, and scanning in both supine and upright position. Dynamic sonography aid in determining hernia type, size, content, reducibility, and tenderness. This is cross-section diagram. Sorry. Rectus muscle, and in between the line elbow. Here is the rectus muscle. This is another rectus muscle, and in between the line elbow. Here, the rectus muscle. This is the linus semionaris, and this is the external oblique muscle, internal oblique muscle, and transverse abdominal muscle. And here is the skin and subcutaneous tissue. This is another picture showing this is the skin, subcutaneous fatty layer, the external oblique muscle, internal oblique, transverse abdominis, and the fascia in between them. This is the transversalis fascia that separates this muscle from the abdominal, small bowel, and abdominal content. The third investigation is CT scan. The three muscles, internal, external oblique, and transverse abdominis, can be seen anterolaterally in cross-section, and also the rectus muscle and its sheath can be seen anterior to the other three muscles. Here is the rectus sheath, the most anterior one, and in between the line elbow. Here anterolaterally, this is the external oblique, internal oblique, and transverse abdominis muscle. We are finishing the anterior abdominal wall. Any question before moving to esophagus? Okay. The esophagus is a 25 cm long fibromuscular tube. It facilitates the passage of food and fluid from the larynx to the stomach under precise nervous regulation. It starts at the level of C6 at the lower border of cricoid cartilage. This is the cricopharyngeal muscle. Demonstrate its upper end. It enters the abdominal cavity via the right crus of the diaphragm. This is the right crus of diaphragm, and enter the abdominal cavity, and at the level of T10, and extending to the cardiac orifice of the stomach at T11. This is the T11. Sorry. This is the T10 where it enters the diaphragm. This is T11 where it joins the stomach. It consists of muscles that run both longitudinally and circularly. Parts of the esophagus. The esophagus consists of three parts: cervical part, thoracic, and abdominal part. The thoracic part starts from the lower end of cricoid cartilage at the level of C6 and until the T1. The thoracic is about, the cervical part is about 4 cm and lie anterior to the lower cervical vertebra. The next is the thoracic part, which extends from T1 to T10, where it leaves the thorax by entering the diaphragmatic hiatus. And it is the longest part, about 18 to 20 cm, and lie anterior to the thoracic vertebra. The last one is the abdominal part, which is the shortest one. It is about 1 to 2 cm from the extend from the diaphragmatic hiatus of the esophagus to the gastroesophageal junction. Relation of esophagus. The cervical part, it descends behind trachea and thyroid and lie anterior to the lower cervical vertebra. This is the esophagus. This is the trachea, lie anterior to it with the thyroid, and the esophagus lie anterior to the cervical vertebra. The carotid sheath on either side with the thyroid lobes also lie on either side. The thoracic part lie anterior, it lie posterior to the trachea, left main bronchus, left atrium, and upper part of left ventricle. And it lie interior, so the posterior relation is the thoracic vertebra. And in this other picture here is the thoracic duct, posterior also, the azygos vein and its tributaries, and the posterior subcostal or intercostal vessels that pass from the aorta, descending aorta. This is the posterior relation. On the left wall, at the level of the origin of left subclavian artery, the arch of aorta lie on the left of the esophagus and impress it. Below this level, this is the esophagus, lie in direct contact with the pleura and lung. Also on the right side, the esophagus is crossed by the azygos vein at the level of T4. And below this level, the azygos vein lie on the right and posterior to the esophagus. Here is the esophagus is pulled apart on the right side, and also lie in direct contact with the pleura and lung. As we mentioned, the arch of aorta first lie at the left side of the esophagus and impress its left wall. Then, as the esophagus move to the left side, it become anterior to the descending aorta, and when it continue to be on the left side, finally it become anterior and to the left of the descending aorta when it enter the diaphragm. The third part is the abdominal part. As we mentioned here, it starts from the hiatus, esophageal hiatus of diaphragm, to the gastroesophageal junction. And here it lies in the retroperitoneum and behind the left lobe of liver. Here is the left lobe is pulled up to demonstrate the abdominal esophagus. The esophagus have 4 physiological constrictions. One in the cervical region here, caused by the cricopharyngeus muscle, which is the upper esophageal sphincter. The second one caused by the aortic arch. As we said, it impressed its left wall. The third caused by, this is the aortic arch impression here in the barium swallow. The left main bronchus. This is the impression caused by left main bronchus. And the final one is caused by diaphragmatic esophageal hiatus. Here, the diaphragm will compress the lower part of the esophagus. Here, let's demonstrate here. The blood supply to the esophagus. The esophagus is divided into 3/3. The upper third supplied by the inferior thyroid artery. This is the branches, esophageal branch of the inferior thyroid artery, which is a branch of the thyrocervical that originate from the subclavian artery. These are the esophageal branches of the inferior thyroid artery in the upper third. The middle third is supplied from aortic esophageal arteries, branches from the descending aorta that supply the esophagus. In the lower third, the esophagus is supplied by ascending branches from left gastric artery. The venous drainage is also follow the same arteries. So in the upper third is drained by the inferior thyroid artery. In the middle third, drained by the azygos vein. And in the lower third is drained by the left gastric vein, which connect it to the portal vein. So there is in the lower part of the esophagus communication between the systemic circulation and portal circulation. The nerve supply of the esophagus. The esophagus has sympathetic and parasympathetic supply. The sympathetic supply is from the sympathetic trunk, while the parasympathetic is from the vagal trunk, the anterior vagal trunk and posterior vagal trunk that form esophageal plexus. Here is the esophageal plexus. This is the posterior vagal trunk, and this is the anterior vagal trunk. The lymphatic drainage of the esophagus is through the paraesophageal lymph nodes. Here, this is the paraesophageal lymph nodes that drain to the posterior mediastinal lymph node, then to the supraclavicular lymph node. While in the lower part, it's drained to the left gastric nodes, which drain them to the celiac nodes. Imaging of the esophagus. Starting with the plain film, AP chest radiography, the right wall of the esophagus and esophagus vein are outlined by link, which seen on frontal film as a zygoesophageal line. And above this level of the esophageal arch, which lie at T4, the right wall, sometimes seen as the pleuroesophageal line. Here, this is a chest X-ray showing this is the zygoesophageal line caused by the right wall of esophagus and esophagus vein. And above T4 should be the, or maybe seen the pleuroesophageal line, but it is not demonstrated in this figure. Lateral chest X-ray. When the esophagus contain air, then the posterior aspect of anterior esophageal wall may be seen posterior to the trachea. This is known as posterior tracheal stripe. This is the posterior tracheal stripe, composed of the anterior esophageal wall, shown here because there is air in the esophagus. This is esophagus, and this is posterior esophageal, the posterior tracheal stripe. The second investigation is the barium swallow. This is the main method for assessing the esophagus. Gas usually swallowed in addition to barium to distend the esophagus and give a double contrast examination. The use of paralyzing agent like Buscopan stop intrinsic esophageal contraction, allowing a better appreciation of the esophageal anatomy. The agents used is either barium sulfate 80% or gastrographene. However, avoid the use of barium if there is a suspicion of esophageal perforation, and avoid gastrographene in case of suspicion tracheoesophageal fistula, as this may cause anaphylaxis and high rate of death. The position during swallowing are erect, then prone, then supine position, and position during imaging are frontal view, lateral view, right anterior oblique, and sometimes left anterior oblique. Starting with the frontal view, there is two in the neck and in the chest. Starting in the neck, the oropharynx in this view may be examined. The piriform fossa are outlined by barium. The epiglottis and base of tongue show as a filling defect in the midline, and the cervical esophagus is seen to curve slightly to the left. This is the frontal view of the barium swallow in the neck. This is the base of the tongue, as we mentioned, the oropharynx. The oropharynx, this is, and the base of the tongue filling defect. This is the vallicula, which is the space between the tongue base and epiglottis, filled with contrast. This is the piriform fossa, as we mentioned, filling also contain contrast, and the esophagus slightly curved left and lie anterior to the esophagus to the cervical vertebra. The frontal view in the chest, the esophagus show left side indentation from aortic arch and left main bronchus, and the lower esophagus curved to the left to enter the stomach. However, in elderly, the course of esophagus may be altered due to unfolding of the aorta. This is a frontal view in the chest. As we see here, this is the impression in the left wall of the esophagus caused by the arch of aorta and left main bronchus. Then it's moved to the left side and forward before entering the abdominal cavity. This is another video. This is the aortic arch and left main bronchus. The second view is the lateral view. On this view, the tongue base and epiglottis are seen from the side with the vallecula between, and a posterior indentation caused by the contraction of the cricopharyngeus muscle to initiate deglutition indicates the commencement of the esophageal proper. And just below this, on the anterior wall of the esophagus, a small impression may be made by submucosal plexus or vein. The cervical esophagus seen to lie on the anterior surface of the cervical vertebra. This is a plain film just to demonstrate the vallecula. This is the epiglottis. This is the base of the tongue, and this is the vallecula in between. Here, when the contrast swallow is taken, this is the base of the tongue. This is the epiglottis, and this is the vallecula in between, containing contrast. Here is the esophagus, lie anterior to the cervical, and this is the contraction here, so, showing the anterior, the beginning of the esophagus. This is the C6. This is the beginning of the esophagus. This is another view, lateral view of the neck. This is the hyoid bone. This is the hypopharynx, and this is the esophagus. Here, as we mentioned, the upper part is show the posterior impression caused by the cricopharyngeus muscle. This impression caused by the cricoid cartilage. And as we mentioned, there is a small impression on the anterior wall caused by the submucosal venous plexus. And this is the esophagus. The third position is the right anterior oblique. In the chest, the esophagus is best demonstrated in this view, and three major impressions are seen in this view anteriorly. From above downward, these are the aortic arch, left main bronchus, and the left atrium. In this position, the esophagus seen to curve anteriorly in its distal part to enter the stomach. This is the right anterior oblique position. This is how the aortic arch impressed the esophagus, and this is how the left atrium impressed the esophagus. Here is the right anterior oblique position in the barium swallow. This is the aortic arch impression. This is impression of left main bronchus, and this is because of impression of left atrium. The lower end of the esophagus has a fusiform dilation just above gastroesophageal junction. This is called the esophageal vestibule. In barium exam, the upper part of the vestibule is defined by a transiently contractile ring known as A ring. The lower end of the vestibule also defined by a transient contractile ring known as B ring or Schatzky ring. The esophageal mucosa arranged in longitudinal folds that are best seen when esophagus not distended. This measure around 3 mm in width. The thicker stomach folds are seen distally, indicating the gastroesophageal junction. And in normal people, this may rise to the thorax during swallowing. Here is a right anterior oblique. First, this is the impression caused by the aortic impression, and this is formed by the left main bronchus. Here is we are talking about the vestibule, the number 4 representing the vestibule, the number 2 representing the upper end of the vestibule, the A ring, and number 3 representing the lower end of the vestibule, the B ring or Schatzky ring. Number 5 is the esophageal hiatus of the diaphragm, and these longitudinal smooth lines or folds, which demarcated by number 6, is the esophageal folds. Number 7 is the gastroesophageal junction. In patient with a sliding hernia, we will see this is the rugal fold, which are not, as we mentioned, is thicker, not that like that the thin folds of the esophagus, thick fold, and the B ring lie above the diaphragm. Here is the diaphragm. This is the B ring, which should be below the diaphragm. Here, it is above the diaphragm. This is the A ring, this is the vestibule, this is the B ring, and this is the sliding hernia. The third investigation is CT and MR. The esophagus also imaged by CT and MRI, and its visualization is improved if it is contained air. When it is collapsed, it's seen as a thin wall structure in the posterior mediastina. Here, this is the esophagus when it is collapsed. without air, as seen as thin-walled structure in the posterior mediastinum, posterior to the trachea. Here, where is the esophagus contain air, is lie anterior to the aorta and posterior to the trachea. This is an MRI of the esophagus. Here is the esophagus, and this is the descending aorta, lie anterior to the descending aorta. We finishing our lecture. Is there any question?
عاشتي ليش دكتورة نور؟ اكو احد عنده سؤال قبل ما نروح للكويز على الاسوفاجاس، على الانتيريور ابدومينال وول، تقسيمات مالته؟ ماكو. اذن نروح على الكويز. نختار اول واحد زهراء علي.
نعم دكتور. Number 1 left atrium impression.
Left
atrium impression.
impression. وش كم impression على الأوسوفاجس normally؟ ايش كم indentation؟
المفروض عندنا 3
بالضبط. اوكي زهرة عاشت ايدك. نروح على الدعاء على نمبر 2.
نعم. نمبر 2 ايرينج.
الايرينج شو يمثل هذا الايرينج؟
شو اسمه الجكشن بين بين الجاستريك والاسوفاجيال جكشن.
اوكي. دعاء سعد نمبر 3.
أستاذ بيرنج.
هذا البيرنج. اوكي. المنطقة بين الايرنج والبيرنج
فيستبيول اللي هي تمثل lower esophageal sphincter high pressure area.
اوكي عايشة. 5 نمبر 4.
أمبولة. نعم أستاذ أمبولة.
أمبولة of the esophagus. دكتور عقيل نمبر 5.
نعم أستاذ، هاي الدايفراماتيك هياتس فور ذا اسوفاجس.
diaphragmatic hiatus اللي هي هم هنا تسوي اندنتيشن على اللور اسوفاجس.
واحدة من الاندنتيشنز.
نمبر 6 وصلنا مو؟ رشاد داخل.
نعم أستاذ. نمبر 6 esophageal mucosa fold.
اللي هي شلون تكون؟ longitudinal مو؟
أستاذ longitudinal.
اوكي. ايش كم تقريبا الميوكوزال فولد عندنا longitudinal ميوكوزال بالاسوفاجس بالنورمال؟
العفو أستاذ، إحنا عندنا circular و longitudinal يعني.
هي اللي بالبيريوم عادة تبين اللونجيتودينال.
longitudinal.
ايش كم وحدة تبين عندنا بالبيريوم بالدبل كونتراست بيريوم سولو؟ من يعرف؟
3 step.
3 أو 4 sometimes. اوكي. نروح على رنين نمبر 7.
نعم. esophagogastric junction or the Z line.
esophagogastric junction اللي هو الزد لاين. دكتورة رشا، اكو فرق باللايننج ميوكوزا بالاسوفاجاس لو كليته السيم لايننج ميوكوزا؟ صفا شامل.
نعم أستاذ.
اكو فرق باللايننج ميوكوزا of the esophagus لو كليته the same epithelial mucosa lining؟
The same.
شلون the same؟ ماكو فرق بين
longitudinal والcircular.
لا قصدي الابيثيال لايننج يعني ميوكوزال. اكو فرق لو ماكو؟ يعني histologically speaking. علا.
نعم أستاذ. أكو فرق يكون من فوق stratified squamous ومن جوا أصور columnar.
بالعكس columnar اللور columnar لو
اللور
والأبر squamous.
squamous.
اوكي زين. بقى لنا نمبر 8.
number 8 diaphragm.
This is the diaphragm, shadow of the diaphragm. وزهراء صباح أخير وحدة رقم 9.
نعم دكتور. This is air in the fundus of stomach.
gastric air bubble. Excellent. اوكي. اكو عندك بعد مو؟
اي دكتور اي اكو.
استاذ محمد تفضل.
نعم استاذ رعد. نمبر 1 على السين.
نعم استاذ. هاي رايت rectus abdominus muscle.
زين. علا رقم 2.
نعم اللينيا ألبا.
لينيا ألبا. زين. نمبر 3 زيد يوسف.
نعم أستاذ. left transversus abdominus muscle.
نعم. شيماء على نمبر 4.
نعم أستاذ. نمبر internal oblique muscle.
نمبر 5 لارا.
نعم أستاذ. نمبر 5 left external oblique muscle.
خلص.
اي خلصنا دكتور.
عاشت يدك